I told you what is hypertension, classification of hypertension, what is preeclampsia, signs and symptoms, etc. Today I'll continue the class on hypertensive disorders. I also told you about the pathology and pathophysiology in pregnancy in hypertensive disorders. I told you what is HELLP syndrome. I think I stopped near the HELLP syndrome. So today we'll talk about complications of hypertension in pregnancy. Now, what are the complications? Complications can be present in the mother and in the fetus. So, in the mother, she can get eclampsia. As you all know, eclampsia is convulsions in a patient who has preeclampsia. When the criteria for preeclampsia are satisfied and she is also throwing convulsions, it is eclampsia. Then, cerebral hemorrhage she can get. That is because of the hypertension. Hypertension, any blood vessels may rupture in the brain, and then she can have cerebral hemorrhage. Cortical blindness if there is cerebral edema, particularly in the occipital region. Pulmonary edema, that is left ventricular failure, she can develop because of the hypertension, hypertensive uh, action of the heart. Heart has to function more, so it is unable to pump blood. There will be backflow into the lungs, and then pulmonary edema will occur. ARDS is adult respiratory distress syndrome as a consequence of pulmonary edema. HELLP syndrome, I had already discussed that. DIC and bleeding. DIC is disseminated intravascular coagulation. I will talk about that in detail later. Renal failure can occur, which can be a tubular necrosis or a cortical necrosis. Hepatic rupture can occur when the small areas of bleeding coalesce, and then it becomes a bigger area of hemorrhage, and then ultimately rupture of the liver can occur. And if liver rupture occurs, it is a very fatal situation because liver is highly vascular, profuse bleeding from the liver will occur. And by the time you diagnose the condition and try to stop the bleeding, the only thing to do is do a laparotomy and try to stop the bleeding, which is again very, very difficult because there are so many blood vessels in the liver. By the time you do all this, patient goes into hemorrhagic shock, and many times we lose the patient. So fortunately, this is not common occurrence. This is quite a rare, but it is possible complication. Abruptio placenta can occur where separation of a normally situated placenta occurs with a retroplacental bleeding and presence of clot. Then sudden postpartum hemorrhage, collapse. Patient will collapse suddenly because of any of these complications. Then what happens to the fetus? Most often the fetus is because the patient goes into spontaneous labor because of a complication, or because we induce labor in order to save the mother. Say, for example, if the mother has developed a HELLP syndrome, or if the mother has developed eclampsia, there we do not want her to continue the pregnancy. So we terminate the pregnancy in whatever the period of gestation. So if it is less than 37 weeks, then the baby is premature. So all the problems associated with prematurity in the baby, like hypothermia, hypoglycemia, hypocalcemia, etc., are all present in the baby, and baby has to be taken care of in a neonatal care unit. IUGR, the intrauterine growth restriction can occur. When does this occur? This occurs if there is vasculopathy, when the changes in the blood vessels are so much, particularly in the severe hypertension, that there is chronic hypoxia to the fetus. Fetus does not get enough blood supply through the placenta because all the placental vessels are also affected. So when the fetus does not get enough blood supply, less nutrients and less oxygen reach the fetus, and so fetal growth is not up to the mark. Fetal weight is very much less. Then intrauterine death. Sometimes when the hypoxia becomes chronic and it is extreme, intrauterine death of the fetus also can occur. So these are the complications in the fetus. Because so many complications are present in preeclampsia, we have to tackle this disease at the earliest and either try to prevent it, or if you can predict which patient is going to develop preeclampsia, it would be ideal, isn't it? If you can say a primary gravida has come, if you can predict, yes, this patient is likely to have preeclampsia, then you can take some precautions before, or you can be more alert in detecting hypertension immediately she develops this problem. So it would be better if we can predict preeclampsia. So various tests have been tried in order to detect which patient is going to develop preeclampsia in future. That means prediction is she is not having the disease now, but she is likely to develop further as the pregnancy is advancing. So can we predict which patient is going to develop preeclampsia? So for this, many tests have been devised. Mean arterial pressure in the second trimester. I told you when I was talking about pathology. Normally, in normal pregnancy in the mid trimester, there is a fall in the blood pressure because of the vasodilatation and reduction in the peripheral resistance in the blood vessels. But by the third trimester, the BP comes back to the pre-pregnancy level, to the normal level. Now, if a patient is tested for blood pressure in the second trimester and the mean arterial pressure is more, 90 millimeters or more. Uh, I've told you what is mean arterial pressure, isn't it? Uh, okay, so if that is more than 90 millimeters of mercury, okay, this patient who should have had a fall in the second trimester because of vasodilatation, probably there is no vasodilatation and constriction is there, and so BP has risen and it is likely to remain high in the third trimester also. So this you can say. But what we have seen is this is not very much dependable. This you may not see in every patient, and so for general screening, this cannot be used. Then Gant's rollover test. See, normally when the woman lies in the supine position, as pregnancy is advancing, because of the weight of the uterus, there is pressure on the inferior vena cava and the pelvic veins. So the blood accumulates in the lower limbs. Blood is not going into the heart, and so there is less pressure. What we call a supine hypotension syndrome that occurs normally. Now, if the woman is then in the left lateral position, turn to left lateral position, this pressure of the weight is not there. So blood pressure will be increasing to her usual level, isn't it? So now if a woman, a normal pregnant woman, is turned from the left lateral position to the supine position, then there should be lessening of the pressure because of the pressure exerted by the pregnant uterus on the veins. Now, in a woman who is going to develop a preeclampsia, when the woman is turned from the left lateral to the supine position, instead of the BP falling, it is increasing. If the increase in diastolic pressure is 20 millimeters or more, then it is a good prediction that she may develop preeclampsia in future. This is a clinical test. Clinical test done very easily, a very simple test. But again, as I told you, it is not 100% reliable. This may be present only in a few patients. Then, angiotensin sensitivity test. Here, uh, normally in a woman, in a pregnant woman, the blood vessels lose their sensitivity to angiotensin. So, if angiotensin is given, these blood vessels do not contract. So, remain, they are refractory to the action of angiotensin. If they contract, what will happen? The blood pressure will rise, isn't it? So, nature has provided this. There is a refractoriness to angiotensin. But in a woman who is going to develop preeclampsia, this refractoriness to angiotensin is lost. They remain sensitive to angiotensin. Between 28th and 32 weeks of gestation, if this woman is given angiotensin infusion, say 8 milligrams per kg per minute is infused, then there is a pressor response. Normally, Because of the refractoriness, there should not be any increase in the blood pressure. But if there is any increase in the blood pressure with angiotensin, that means the sensitivity is not lost. So this woman is likely to develop preeclampsia. So this we see in about 90% they say, but again this is not 100% reliable. Uterine artery Doppler. In a normal pregnancy, diastolic flow increases as pregnancy is advancing because of the vasodilatation and reduction in the peripheral resistance. So, the notching in the Doppler of the uterine artery will disappear. See, the details I cannot tell you now. Uh, when we talk about intrapartum surveillance, antepartum surveillance, this will be told to you. Then, persistence of this diastolic notch in uterine artery Doppler at 20 to 22 weeks. This means by 20 to 22 weeks, this notching should disappear because the blood supply improves. But if this is still persisting, then you can say yes, this woman may develop preeclampsia in future. This is supposed to be one of the one very reliable test, though it not seen again, not seen in 100% of the patients. Then fibronectin. Fibronectin is a component of connective tissue and the basement membrane. And here in blood vessels, since there is damage to the connective tissue and basement membrane, you see the increased plasma levels in preeclampsia. So they naturally precede the appearance of the blood pressure because it's a part of the pathological process. So if this is detected ahead of the patient developing preeclampsia, yes, you can say this is a predictor. Then hypocalciuria, less than 12 milligrams per 100 ml in 24 hours urine. This is calcium level or a low calcium creatinine in urine. If it is less than 0.04, then this is supposed to be indicative of as a predictor of preeclampsia. Then other parameters like raised serum beta HCG at 14 to 20 weeks, raised serum uric acid, or raised serum inhibin A at 14 weeks. All these, they are not specific for only patients who develop preeclampsia. They are not specific. They are seen in other conditions also. So again, they are not completely reliable. So many tests have been devised, have been tried, and still many more tests are being tried, but still there is no single good predictor for preeclampsia. Yes. Now, Now, is there any prophylaxis? Suppose a patient has high risk factors. I have told you all the risk factors, isn't it? A primi gravida, or a patient with chronic hypertension, or a patient with Upler syndrome, or SLE, previous history of preeclampsia. All these high risk factors, if in a patient with high risk factors, then can you give something to prevent development of preeclampsia? Can you give something to the mother, some drug, some um, which can prevent preeclampsia? Yes. One of the most tried and most dependable is aspirin. Simple aspirin. Previously, aspirin used to be taken for all sorts of pains, headache, and you must have seen the advertisements also. Okay, this was before your generation. In our younger days, yes, aspirin was only analgesic available, to tell you frankly, say 40, 50 years back. But now, again, this aspirin is, though now aspirin is not being used for other, as analgesic for other conditions, because one of the dangers with aspirin is it can cause gastric bleeding, gastric ulceration, particularly in the aged people. It can cause hematemesis and then bleeding per rectum, etc. So it is not being much used, but it is useful for a treatment of as a prophylaxis in patients, pregnant women who have a chance to develop preeclampsia. So low dose aspirin is given. Low dose, that is 75 milligrams daily. Now, how does this aspirin prevent hypertension? It inhibits the cyclooxygenase enzyme in the platelet. Now, this in the platelet, This cyclooxygenase enzyme is involved in the production of thromboxane. So thromboxane is a vasoconstrictor. So if the cyclooxygenase enzyme is inhibited, then there is less production or no production of thromboxane, and so vasoconstrictors are reduced, and so a normal balance between the vasodilators and vasoconstrictors will be maintained. Less of thromboxane and more of prostacyclin. Prostacyclin is a vasodilator. So then there is vasodilatation, so peripheral resistance is reduced, hypertension is reduced. So this is given to the high risk women. Now it is started early. You see, there is no point in starting it after the patient develops hypertension. This is for a prevention, prophylaxis. So you start it early as possible. Many places they immediately the patient misses period. This is started, or at least by 10 to 12 weeks in the first time. That means in the first trimester itself, you have to start this. Every day, patient must take 75 milligrams. And then you stop the treatment at 34 weeks, because by 34 weeks, we consider the fetus to be mature. And then we do not want it to be given till the patient delivers, because aspirin also affects the coagulation process. And if it is continued, then bleeding may be present in the fetus. See, whatever the mother takes goes to the fetus also, always remember. So it is given only till 34 weeks. Then other agents have been tried, like antioxidants. Antioxidants, they act as scavengers of free oxygen radicals. That is, scavengers means they remove the free oxygen radicals from the system. So vitamin C 1000 milligrams per day, vitamin E 400 units per day, and lycopene. All these antioxidants have been tried. They have been successful in some patients, not successful in other patients, etc. Then folic acid has been tried because it reduces hyperhomocystinemia. I told you there is hyperhomocystinemia in preeclampsia. So this reduces hyperhomocystinemia, and thereby hoping that it will reduce the blood pressure. This has been tried. Then calcium supplements. So hypocalciuria is present in the this thing and in the body, and there is less calcium. So calcium supplements have been tried. So all these measures for prophylaxis, out of all these, more reliable are the aspirin and also calcium supplements. That's all. All others, yes. Uh, some people, do you see the response? Some people, you don't see the response. So that is all about the prevention of preeclampsia. Now, management. How do you manage a patient with preeclampsia? Now, mild preeclampsia, usually, just bed rest is more than enough. Um, uh, we say left lateral position because it improves blood supply to the heart, and so reduces the hypertension. And also taking more rest, reduces the anxiety for the mother, and a better blood supply to the fetus, so less IUGR. So all over, it is helpful. Then there is no role for sedation. There is no need to sedate the patient. That is not going to reduce her blood pressure. There is no rule for salt restriction. See, in a non-pregnant person, whether male or female, generally in a hypertensive patient, they are advised to take less salt, because their increased salt intake goes a long way in increasing the blood pressure. Here, salt has no role. Sodium chloride has no role in either development of the hypertension or prevention of hypertension here. So there is no rule for salt restriction. There is no role for diuretics. So in a non-pregnant hypertensive patients, they are advised diuretics in order for reducing blood pressure. But here we do not give in pregnancy, because diuretics they do not help in reducing hypertension. Moreover, they increase the pathological process in hypertension. Why? Because there is more fluid lost from the body when you give diuretics. Say more urine, and so more fluid is lost. All this comes from where? From the vascular compartment, isn't it? Already in hypertension, there is exudation of fluid into the various extravascular spaces. That is why patient develops edema. So then there is already hemoconcentration. This causes hemoconcentration. So if you give more of these diuretics, more fluid is lost from the body and more hemoconcentration and more chances for thrombosis, etc. And also they have a direct effect on the fetus. They reduce the uteroplacental blood flow because of a less blood volume and increase the growth restriction. So because of these reasons, we do not routinely give diuretics in pregnancy. The only indication would be when we want an acute loss of fluid from the body, like in pulmonary edema. Pulmonary edema, you want to reduce the edema in the lungs. So that's like an emergency. So that's the only condition where you give diuretics. Or another condition is where renal failure is there. Acute renal failure in the initial stages, you may give diuretics to improve the urine output. Apart from this, there is no role for diuretics. Yes, so this is all in the mild cases of preeclampsia. And do you give antihypertensive in mild cases? Usually, they are not indicated in all cases. Only when the severe hypertension is there, when the blood pressure is more than 160 by 100 millimeters of mercury, then we give antihypertensives. Usually, just simple treatment will reduce the hypertension or at least keep it under control. Now, what are all the antihypertensives which are used in pregnancy? See, all antihypertensives which are used in non-pregnant condition cannot be used in pregnancy. Many of them have not been tried in pregnancy also because of the danger of side effects and effect on the fetus. So, see here, and we are treating not only the mother, the fetus also. So, any medication we have to give very carefully. So, only a few drugs are given in pregnancy: alpha methyl dopa, nifedipine, hydralazine, labetalol, and atenolol. Atenolol also not frequently. Now, since labetalol has been introduced, use of atenolol also has reduced. Now, this chart shows the various drugs and their mode of action. Alpha methyl dopa, it has a central nervous action. It's available as 500, 250 and 500 milligram tablets, given 1000 to 2000 milligrams per day, 3 to 4 times in divided doses. The side effects are there is postural hypotension, depression, and sometimes hemolytic anemia. Nifedipine. Nifedipine is a calcium channel blocker. It acts at the peripheral vascular level, causes vasodilatation. That means it prevents the entry of calcium into the through the membrane of the endothelial cells into the endothelial cell. So the endothelial cell cannot. There is no contraction of the blood vessels. It remains so dilated, and blood pressure will reduce. They are available as 5 milligram tablets and 10 milligram tablets. We give 20 to 40 milligrams per day in divided doses. Now, since this is a vasodilator, it is you see the side effects are headache, flushing of the face, then palpitations because of then acute hypotension. The heart starts beating more. There is tachycardia, so palpitations. Then hydrolysine, again, it's a peripheral vasodilator. It is also available as 10 milligram tablets, 50 to 300 milligrams per day in divided doses. Same side effects because it's a vasodilator: headache, flushing, tachycardia, and with hydrolysine, a lupus-like syndrome is seen some on a prolonged use. Lupus erythematosus, no, the systemic lupus erythematosus like syndrome is seen. Then labetalol. Labetalol is a sympathetic blocker. It is adrenergic blocker. It's a combined alpha and beta blocker. You know, alpha receptors and beta receptors are there in the sympathetic system. So it's a combined blocks both alpha and beta receptors. They're available as 100 milligrams tablets. It's also available intravenous preparation is there, 10 milligrams per ml, which is used for reducing acute rise in hypertension. Then 200 to 400 milligrams per day in 2 doses. This side effects is postural hypotension and sometimes tremulousness. That is mild, tremors like that. Then atenolol, I told you it's we have almost stopped using it, but it is a beta blocker. It is given in 50 to 200 milligrams per day. See, the because it's only isolated beta blocker, the side effects are more. Bradycardia may be there, hypotension, hypoglycemia, fatigue, IUGR. So, because of all these side effects, it's been slowly given up. So, out of all these drugs, the most common ones we are using now are nifedipine and labetalol. Right. And then you have admitted the patient. See, any patient with hypertension, whenever you see the patient, you admit her for monitoring the hypertension, for evaluation, for doing the all the investigations that I have told you in the last week, and then for treating the patient. So, how do you monitor this patient? Every day you are seeing the patient. You are visiting the ward, you are making your rounds, you are seeing the patient. Yes, please, somebody is. Please close your microphone. Somebody's voice, some noise. Check the blood pressure at least 4 times daily. At least 4 times daily. That is 6 hourly. Then urine albumin should be checked daily. You got urine albumin to check. Strips are available. You have to check every day the presence of, because the presence of protein in the urine means her kidneys function is getting involved. It is getting damaged. So that means she may go into a severe hypertension, and we have to be cautious and try to deliver early. Then body weight you can check frequently, because an increase in body weight means there is fluid retention. All the tests, blood tests that I have already enumerated, liver function tests, kidney function tests, then coagulation profile, etc., should be done at least twice weekly to know the condition of the mother, to see if she is developing any complication, any organ involvement is there. Then daily fetal movement count. The mother should be told to check for the fetal movement. That is fetal kick count. She must note down every time the fetus moves. She must note down on the paper, and then she must tell you how many movements were there per day. So if not 24 hours, because the patient also has to sleep. So during the waking hours, say for about 10 to 12 hours, say 9 to 9, she can check up and give you the count the next day. There should be a minimum of 10 moments, fetal moments in a period of 10 to 12 hours. That is the minimum. If it is less than that, that means what is happening? The fetus is becoming compromised. The patient's problem is increasing. Then you will think of an early termination of pregnancy. Then you have to do ultrasonogram to assess the fetal growth. Every 2 to 3 weeks, you have to see whether the fetus is growing normally or not, if there is any growth restriction. And also, you can do the AFI, that is amniotic fluid index, and the biophysical profile. All these are the antepartum surveillance tests, which class has already been taken, I think, or it will be taken later. Then NST is non-stress test, which again tells us about the fetal condition. And then amniotic fluid volume assessment. I told you amniotic fluid index. So all these have to be assessed, what we call fetal surveillance, to know about the fetus, to know the condition of the fetus. If there is fetal compromise, then we have to think about termination. Okay. Doppler velocimetry has to be done to know whether what is the blood flow in the uterine artery, what is the blood flow in the umbilical artery, and in the middle cerebral artery in the fetus. So all this will tell us about the condition in the fetus. Then condition in the mother, you will know by the blood pressure check and then all the investigations that you do twice weekly. So if everything, all these tests are normal, you will allow the pregnancy to continue for some more time, or at least till the fetus reaches lung maturity, and then you will terminate the pregnancy. See, the whole idea of doing all these tests is to know the condition of the mother and to know the condition of the fetus, so that you can take some active decision and active management whenever they are compromised, either the mother or the fetus, whenever they are compromised. Right. Then delivery. When do you deliver this patient? See, usually a patient with hypertension, we do not want her to continue the pregnancy beyond the stage of fetal maturity because she may develop a complication. She may develop any organ involvement and a complication. So, you would like to see that the mother is healthy, isn't it? So, you deliver by 37 weeks once the fetal lung reaches maturity. If it is less than that, if the duration of pregnancy is less than, particularly if it is less than 34 weeks, and you need to deliver the patient, then it's better you give antenatal corticosteroids. That is, betamethasone 2 doses we give uh, now with a gap of 24 hours. So this helps in the accelerating the fetal lung maturity. So once this is given, then you can deliver. So we plan the delivery like that. Now, if how to deliver? If cervix is favorable, you can do an ARM and oxytocin infusion. If cervix is unfavorable, that means if the Bishop score is less than 5. You all know what is Bishop score. Bishop score, some parameters are taken for the cervix, condition of the cervix. I will not go into the detail. Please look up in the books. Now, if there is a scoring system for this, if the cervix is long, os is closed, and it is facing posteriorly, placed posteriorly, uh, then it is not favorable. So if the cervix is not favorable, you can give prostaglandin gel or misoprostol. Uh, uh, Misoprostol, that is a prostaglandin E1 or prostaglandin gel intracervical, and then you cervix will become favorable. That is, there will be shortening of the cervix, os will open up, uterine contractions will start, patient will be early labor. Then you can accelerate with oxytocin. And during labor, continuous monitoring with CTG is ideal. So, because with the uterine contractions, if there is fetal compromise, if such fetuses, say IUGR is present, such a fetus will not be able to tolerate the uterine contractions. There will be hypoxia, and then fetal tachycardia or decelerations, etc., will appear in this on the CTG. That is the time when, for the sake of the fetus, you may have to do a cesarean section. So, a continuous CTG monitoring during labor will be very helpful. CTG monitoring is nothing but monitoring the fetal heart rate, particularly in relation to the uterine contractions. Right. Then, after delivery, you avoid ergometrin, that is, method ergometrin usually, or prostaglandin F2 alpha we give to reduce postpartum bleeding. But ergometrin should be avoided because there is acute contraction of the uterus. Not only the uterus, blood vessels contract, and then there is spike of hypertension at that time, and then some complications she may develop, say cerebrovascular hemorrhage she can develop. So we usually avoid ergometry. Then when do we do? Is preeclampsia an indication for cesarean section by itself? No, it by itself it is not an indication. Vaginal delivery can always be given. We do a cesarean section only for obstetric indications, other obstetric indications. Say, for example, there is a breech presentation, a footling breech presentation, which is an indication for cesarean section by itself. Or severe growth restriction is there. Say, baby is only 1.5 kg and the NST is showing some abnormalities. Then this baby cannot go through the vaginal delivery, contractions during vaginal delivery. So we do a cesarean section. Or say contracted pelvis is there. So whether the patient has hypertension or no hypertension, contracted pelvis is an indication for cesarean section. So like that, cesarean section is done only for obstetric indications. By itself, preeclampsia is not an indication for cesarean section. Right. Now, all this what I have told you is management of a mild or moderate preeclampsia. Now, suppose severe preeclampsia is there. Now, how do we know the severity of the preeclampsia? I have already told you in the last class what are all the signs, symptoms, and investigations findings which will tell you that there is severity of the disease. Blood pressure, say more than 160 by 110 millimeters, or severe IUGR is there, or mother has developed a complication like proteinuria, high proteinuria, more than 2 plus, then or HELLP syndrome is there, or patient has developed renal failure or pulmonary edema. All these are indicative of severe preeclampsia. So if there is severe preeclampsia, there is no place for any expectant management. You can't wait. You can't wait anymore. So here you have to terminate the pregnancy. Ideal would be termination of the pregnancy. So only definitive management for severe preeclampsia is delivery. But suppose it is less than 24 weeks, terminate the pregnancy. If this baby cannot be salvaged, you just simply do an abortion. Terminate the pregnancy. Now, after 34 weeks, fetus is matured. There's no point in waiting. You deliver the baby either vaginally or uh, by cesarean section, depending upon the situation, about the condition. Now, the problem will come when the pregnancy is between 24 weeks and 34 weeks. Here, the fetus is not is has reached the period of viability. No, though not maturity, viability. So, a viable fetus should we terminate, do an abortion? That is a problem, isn't it? Again, suppose you deliver because but the fetus is not mature. So the fetus, because of lack of fetal maturity, baby needs a lot of care in the NICU. Very expensive. Not only that, may develop complications, may or may not survive. So the problem is between 24 and 34 weeks. So here what we do is we give initial treatment. Initial give antihypertensive, do investigations, etc. And if patient condition stabilizes, BP comes down, all the investigations become normal, urine output is good, then we continue the pregnancy giving expectant management, but only in the hospital. This patient cannot be sent home. This patient has to be treated in the hospital only. Now, how do we know do this expectant management? By giving antihypertensives, monitoring of maternal condition, fetal condition, and then by 34 weeks give corticosteroids, antenatal corticosteroids for lung maturity, and deliver the patient as early as possible. At least by 34 weeks, you immediately after 34 weeks you deliver the patient. That is the expectant management. But if any time patient develops a severe complication, terminate the pregnancy irrespective of the gestational age, whether it is 28 weeks, 30 weeks, 32 weeks, whatever, patient develops a complication like, say, eclampsia or HELLP syndrome or any other complication, you terminate the pregnancy. So that is how you manage a severe preeclampsia. Before 24 weeks, terminate the pregnancy. After 34 weeks, deliver. Between 24 and 34 weeks, expectant management only if the patient is responding. If the patient doesn't respond or develops a complication, terminate the pregnancy, whether whatever the period of gestation. Now, when do you terminate? You are giving expectant management. When do you terminate? I told you when the patient develops some complication. So, when uncontrolled hypertension, you are giving all antihypertensives, high doses you have been trying, but still patient is not responding, and there is a danger of intravascular hemorrhage or cerebral thrombosis, etc. So you terminate the pregnancy. If she develops signs of imminent eclampsia or she develops eclampsia, there are abnormal renal or liver function tests, or she's developed coagulopathy, that is bleeding time, clotting time has increased, prothrombin time has increased. That means she's going into DIC. Then HELLP syndrome or acute fetal distress. Fetal condition is not normal. Your NST shows that the fetus is affected. Continuous late decelerations are present. Severe growth restriction is there in the fetus. Then placental abruption, abruptio placenta is there, massive separation of the placenta. You can't continue the pregnancy, you have to terminate the pregnancy. Or after expectant management, patient has reached 34 weeks, and here once she has reached 34 weeks, fetus lung maturity is present, so you can terminate the pregnancy. No point in continuing the pregnancy for some more time. While you are continuing, patient may deteriorate, isn't it? So once 34 weeks is reached, terminate the pregnancy, deliver the baby. So these are the indications for termination in severe hypertension, severe preeclampsia, which where you have given the expectant management. Now, during delivery, what do you do in a patient with Hypertension, intrapartum management. You control blood pressure, give labetalol as a, if for acute rise in blood pressure, IV preparation is available, I told you. So labetalol, IV infusion, 2 milligrams per minute, or you can give that is as a continuous infusion or as a bolus. If you are giving, give 20 milligrams in 2 to 3 minutes. Wait, sit with the patient, check her blood pressure, because sudden drop in blood pressure, hypotension, patient may become unconscious. So you keep checking her blood pressure. If the blood pressure is not reduced, 10 minutes later again you can repeat. Like that you can repeat up to 80 milligrams per day labetalol, intravenous preparation. Okay. Then hydrolysine also has been given 5 milligrams, again intravenous bolus, similar to labetalol. You can repeat it as necessary. Then nifedipine also has been given for hypertensive crisis. Previously, we used to give sublingually, but now, but sublingual nifedipine, the absorption is erratic. Though immediate absorption is there directly into the circulatory, bypassing the gastric circulation, gastrointestinal circulation, but there is erratic absorption and sudden drops in blood pressure, or the sudden or there is no effect on the blood pressure. Because of this, nifedipine is given orally only for acute hypertension also. Then, when you are giving this, a rapid fall in blood pressure should be avoided. Why? Because what is the danger? Another big danger is placental perfusion will reduce. Placental supply will, if the BP falls, blood supply to various organs is reduced, isn't it? So blood supply to the placenta is also reduced. So fetus will get less blood supply, and acute hypoxia, even fetal death can occur. So you have to do this very carefully. You should not move away from the mother. Then you can give prophylactic anticonvulsants. Though the patient has not developed eclampsia, though the patient has not developed convulsions, still in severe hypertension, as a prophylaxis, magnesium sulfate you can give. Richard's regimen can be given for 24 hours. This I will tell you while talking about eclampsia. Now, fluid management, fluid overload should be avoided because she can go into pulmonary edema. Central venous pressure line should. This is all the general management. If coagulopathy is present, or blood products like platelets or fibrinogen has to be given. Now, corticosteroids to reduce blood pressure or for severe hypertension is generally not given, only for accelerating fetal lung maturity. Even I told you in HELLP syndrome also now they are saying that they are not useful. So the only indication for steroids in hypertension is to improve fetal lung maturity. Then obstetric management, you can induce labor after 34 weeks, continuous CTG monitoring, I told you, during labor. Prolonged labor should be avoided. Epidural analgesia can be given. It prevents acute rise in blood pressure because of pain, reduces the pain, isn't it? Patient will be more cooperative, and those acute increase in blood pressure with the pain will reduce. And the same will be useful for doing a cesarean section if for some reason, say fetal distress is there, you want to convert it into a cesarean section, immediately you can do it because already patient is under epidural analgesia. General anesthesia is dangerous. Why? Because edema, along with the edema in all parts of the body, there is laryngeal edema also. This makes the intubation very difficult. And there is also during intubation, there is sudden hypertension, which is highly dangerous. Yes. Then, if you are given prophylactic magnesium sulfate, you must always inform the anesthetist, because then the anesthetist, if general anesthesia is for some reason general anesthesia is being given, anesthetist then will then reduce the dose of muscle relaxant that he is giving. Otherwise, synergistic effect will be there, more muscle relaxation because of magnesium sulfate and the muscle relaxant anesthetist is giving, and then patient recovery will be very 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 late. So that danger is there. So you must always inform the anesthetist. Right. Then, as I told you, indications for cesarean section are only obstetric indications. or a failed induction, or maternal condition is worsening and she's not responding to your induction, you have to deliver her immediately. Acute fetal distress or severe IUGR, and other obstetric indications. Then, after delivery, postpartum management. As I told you, prophylactic ergometrin is contraindicated. Oxytocin can be used to prevent bleeding, but at any rate, PPH should be avoided. Cross-match blood should be kept ready, of course. Aggressive fluid therapy should be avoided. Then after delivery, also you have to do all the blood tests that I have told you before delivery. That is liver function tests, kidney function tests, coagulation tests, etc. Because the patient is still at risk. Even though patient has delivered, patient is still at risk. So and still she can develop convulsions. Then magnesium sulfate, if you have given, you must continue for 24 hours after delivery. And antihypertensives also can be continued after delivery. And if the BP is coming down, then you can taper them off slowly. Now, eclampsia. Eclampsia is development of convulsions in a woman with preeclampsia. There are three types: antepartum, intrapartum, and postpartum, depending upon when the convulsions have occurred: before labor, during labor, or postpartum. Up to 4 weeks after delivery, convulsions can occur because of eclampsia. Intercurrent eclampsia is nowadays is very rare, where the patient develops convulsions, recovers, and then pregnancy continues. This is a risk. See, suppose the patient recovers, and we allow the patient pregnancy to continue. Again, there's always a danger of patient developing convulsions, isn't it? So it is a very high risk you will be taking if you allow the patient to continue the pregnancy. So now there is no rule for any intercurrent eclampsia. Once eclampsia occurs, we are 99.9% we terminate the pregnancy. Now, phases of a seizure, it is like a grand mal convulsions. There is a prodromal phase where there is aura followed by movements around mouth. There is a tonic phase where the body becomes rigid, face contorted, respiration ceases. That is continuous contraction, tonic phase means, lasting for 15 to 20 seconds. Then a clonic phase where there is alternate contraction and relaxation of muscles. So resembling grand mal convulsions. Starting from phase, the convulsions start from phase, then involve the entire body and lasting for approximately 1 minute. Then there is the recovery phase, which is the stage of coma, which is variable duration, may last 1 hour, 2 hour, etc. Right. Now, what is the differential diagnosis? All the other causes for convulsions in a non-pregnant woman can develop in pregnancy also. So, all these are your differential diagnosis: epilepsy, cerebral hemorrhage, cerebral thrombosis, infections like encephalitis, meningitis, cerebral malaria, then any metabolic disturbances like hypoglycemia. Hypoglycemia can cause convulsions. So all this you have to rule out uh, to differentiate eclampsia. Right. Then how do you manage eclampsia? You take general measures. Patient should be nursed in the left lateral position in a cot with railings, because during convulsions she can fall down and hurt herself. She may develop an additional problem of a fractured head injury or a fracture arm or leg. So you have to nurse her in a special cot. Then airway, a lot of secretions will come in the throat and the pharynx. So airway has to be kept open. So nasopharyngeal suction should be done. Then IV line should be started. Start a ringer lactate. Oxygen saturation you measure by pulse oximeter, because during convulsions oxygen saturation will fall, and this will cause hypoxia in the fetus. Then bladder characterization should be done, and the intake output chart should be made. Mouth gag should be kept, because tongue biting can occur like any other convulsions, epilepsy or any other convulsions also. You place a mouth gag in the mouth, isn't it? Like that you must place. Then that is the general management. Medical management, you give anticonvulsant. Particularly, what we are using is the magnesium sulfate. Most effective and most commonly used drug is magnesium sulfate. It can be given by a combination of IV and IM, combination, what we call a pre-charge regime. That is what is being used in many places. Or a continuous intravenous infusion also can be used, like Zuspans or other regimes. Now, this magnesium sulfate, how does it act? It acts at the neuromuscular junction. It competes with calcium for entry into the cells. So calcium entry will not be there, the muscle cell cannot contract. So convulsions will reduce. Now, how do we give this? Loading dose is 20 ml of 20% magnesium solution. That becomes 4 grams. It is given slowly intravenously over 10 minutes. Then, at the same time, you also give 50% magnesium solution, that is 10 ml, that is 5 grams in each buttock intramuscularly, deep intramuscularly, in the gluteal muscle, not into the fat in the buttock where absorption will be less, into the gluteal muscle in the buttock with a long needle you have to take and give. So this is the loading dose. Then maintenance dose you give again intramuscularly in the pre-charge regime, 10 ml, that is 5 grams of 50% solution in alternate buttocks every 4 hours. That means you are giving 5 grams every 4 hours to the patient. We give in alternate buttocks so that to reduce the pain. If you give in the same buttock, that buttock will become swollen and very painful for the patient. So we alternate between the buttocks. And this regime you continue till 24 hours after delivery, or that is if the convulsions have occurred before delivery. Now, if the convulsions have occurred after delivery, that is in the postpartum period, what we call postpartum eclampsia, then you give 24 hours for 24 hours after the last seizure. Note down what time was the last convulsion and give for 24 hours after that. But suppose with in spite of giving the loading dose, patient is having recurrent seizures, you can give another bolus of 2 grams intravenously, 20% solution. Right. Then this is a toxic. Magnesium sulfate is it has to be given carefully. You can't just give and keep quiet. You have to monitor for the patient to see for any magnesium toxicity. So what are all the parameters that you know? Down patellar reflex. Patellar reflex becomes absent if there is toxicity. Urine output should be there at least 100 ml in the preceding 4 hours. If it is less than that, do not give magnesium sulfate because this is toxic to the kidneys. Then respiratory rate becomes reduced if toxicity is there. So respiratory rate should be normal. So all these three, urine output, respiratory rate, patellar reflex, you d- note down before giving the next dose of intramuscular uh, magnesium sulfate. If any one of them is abnormal, you skip the dose. Now, the therapeutic range of plasma magnesium levels is 4 to 8 milliequivalents per liter. If you have the facilities to do this every 4 hours, that is plasma level estimation, then that would be fine. That will tell you whether it's therapeutic range, or anything more than 8 means it is reaching the toxic levels. Right. Then suppose toxicity is there. What do? You give the antidote calcium gluconate, 10% calcium gluconate, 10 ml intravenously. And absolute contraindications for magnesium sulfate are myasthenia gravis and present myocardial infarction. Myocardial infarction because it will cause heart block. It will reduce the contraction of the heart. Myasthenia gravis, it is a condition where there is excessive relaxation of the muscle, so that will be aggravated by the magnesium sulfate. Right. And in addition to this anticonvulsant treatment, you also give other management as you give in a severe preeclampsia, antihypertensives, fluid management, etc. Now, there's a condition called status eclampticus, where the patient is, in spite of giving your magnesium sulfate, patient is still throwing fish continuously, like status epilepticus. The status eclampticus also there. Here, she will not respond to your magnesium sulfate. So there is no time also in between for the patient to breathe also. So what do you do? You give thiopentone sodium, but this has to be done by the anesthetist under supervision. Here the patient has to be intubated, that is endotracheal tube has to be put into the trachea and oxygen has to be given, supplemented through the endotracheal tube. And so this is assisted ventilation. Obstetric management, immediate termination, control the seizures and immediately terminate. deliver the patient as speedily as possible. If convulsions are not controlled and the patient is not likely to deliver immediately, if the cervix is unfavorable, she is not getting good contractions, etc., you do a cesarean section.